Tes tes.
Nampak tak?
Pak.
Okay, thank you.
Yes. Nampak slide tak?
Nampak.
Kalau ni full screen
Full screen.
Alright.
Assalamu alaikum.
Waalaikumsalam, Doctor.
How are you?
Alhamdulillah, we are fine.
Alhamdulillah, all was fine. Today you are presenting the dermatology.
Yes, inshallah.
Okay. All of you are able to pray Al-Asr or not? Because I just finished the prayer. If not, let us try to finish a bit early so you can do it, inshallah, before Maghrib. Okay? The first presenter will be?
Me, Hisham.
Sorry, Hisham. Okay, Hisham, just start by Al-Kitab and go ahead.
Okay, inshallah. Al-Fatiha. Assalamualaikum warahmatullahi wabarakatuh. So, inshallah, today we will have dermatology seminar supervised by our beloved Professor Dr. Mossad. And there are 4 topics, which is Hemangioma, Ectopic Dermatitis, Scabies, and lastly, Stevens-Johnson syndrome. And I will be presenting about Hemangioma. So, this is the flow of contents. So, what is Hemangioma? Hemangioma is blood vessel tumor. It is benign of origin and rarely transformed to malignant. Hemangioma originates from proliferation of vascular endothelium, and it looks like a bright red birthmark that shows up at birth or in the first or second week of life. So for epidemiology of hemangioma, it occurs in 5% of newborns. The risk factors are it occurs more in female, prematurity, low birth weight, multiple gestation, and also white race. For onset, 55% are present at birth, and the rest develop in the first weeks of life. So now we will look at very important point, which is the pathogenesis of hemangioma. So there are no certain direct cause of hemangioma, but according to theory, there is one established theory that is it suggestive of hypoxia that may have the key role in causing hemangioma. So when hypoxia occur, the body will release hypoxia-inducible factor 1 alpha, and this factor will cause transcription of vascular endothelial growth factor, GLUT1, and also insulin-like growth factor 2. So all these factors are called as angiogenic factors, which cause and enhance the proliferation and differentiation of endothelium. Then it will start to proliferate as hemostatic attempt to repair the hypoxic tissue. And lastly, it will have involutional phase as it will regress, and usually it will leave scar or any skin lesion. So these are the diagrammatic of the pathogenesis if you want to appreciate it in visual. So next we move into the clinical course of hemangioma. So as you can see at the graph, hemangioma usually start to rapidly grow from the first week of birth until the 4th week. That is called the proliferation phase. And starting 6 plus 1, it will have a slow growth. And from that into 24 months or second year, it will have called plateau, which is it does not grow, and it is characterized by a more compressible papule. And at about 24 months or after 2 years, it will start to involute, and usually after at 5 years old, it will regress completely. So for maximal regression, 50% of infant will have complete regression at 5 years old, 70% at 7 years old, and by 9 years old, we can say that almost all child has regressed their hemangioma. And the sign of maximal regression is hypopigmentation, fibrofatty deposition, and also scar. So then we move to the clinical subtype of hemangioma. The first type is the superficial hemangioma. It is the most common form, which is about 50 to 60%. It is also known as strawberry or capillary hemangioma because of its look. It looks like a bright red papule. It is sharply circumscribed and compressible, which means it is squishy, and it will reach its maximum size by 6 or 8 months. The second subtype is deep hemangioma. Comparative to superficial, deep hemangioma is less common, which is about 10 to 15%. It has a typical presentation, which is slight bluish discoloration, because compared to superficial hemangioma, deep hemangioma occurred beneath the skin. So it has the bluish discoloration. It is also soft and warm, and compared to superficial, deep hemangioma is more diffuse and less defined, and it can grow up to 12 or 14 months. The third type is the mixed hemangioma. It comprises 25 to 35% of cases. It constitutes both deep and superficial hemangioma characteristics. And the fourth subtype is known as multiple neonatal hemangiomatosis. It comprises 15 to 30% of cases. It characterized by multiple small lesions ranging from few millimeters to 1 to 2 centimeters. It is numerous and multifocal, and multiple neonatal hemangiomatosis may occur in skin as well as visceral organs. And one of the most common sites for visceral organs is liver. And this is dangerous because an infantile hepatic hemangioma can cause congestive cardiac failure, which I will explain later. So this diagram will show you how to appreciate the superficial and deep hemangioma. So you can see for superficial, it occurred on the skin, and for deep, it is beneath the skin with skin underlying the mass, overlying the mass. So next, we move to the clinical features. So hemangioma, it may present at birth or more often appears in the first 2 weeks of life. It is presented by erythematous or blue marks or an area of pallor, which subsequently develops a fine telangiectatic pattern before the growth phase. For hemangioma, the favorite sites are the face, scalp, back, and anterior chest, and more than 50% are located in head and neck. It also associated with patterns of facial involvement such as at frontotemporal, maxillary, mandibular, and frontonasal region. The lesions may be solitary or multiple, but as I said before, if it is more than one lesion, it increases the risk of getting visceral hemangioma. We will anticipate regression of the hemangioma when it develops pale gray areas at the center, and after involution, it may there will remain residual skin such as scar. 1% of hemangioma can be life-threatening, and 10% can cause impairment due to their location, such as at eye and at upper respiratory tract. So this is the picture. I want you to appreciate the upper picture, which show the precursor lesion for hemangioma. So you can see the pale, which is demarcated clearly, the pallor. And this picture show how hemangioma usually regress in a non-complicated case. So now we move to complications of hemangioma. The first most common is ulceration, and it increased risk of infection and hemorrhage. And among the most common type bacteria that infect hemangioma and cause ulceration, such as Staph aureus or Pseudomonas aeruginosa. Second complication is tissue destruction and severe disfigurement in case of big, massive hemangioma. This also will cause psychology impact on the parents. So we must know that. The third complication is large segmental hemangioma, Large segmental hemangioma means formation of large hemangioma at certain sites, such as at the perineum or at the face, head, and scalp. And if there is large segmental hemangioma, it indicates underlying malformation of blood vessel, heart, or nervous system, such as in face and pelvis syndrome, in which I will describe later. And the fourth complication of hemangioma is known as Kasabach-Merritt phenomenon. It is a complication of caposiform hemangioendothelium and punctured hemangioma. Kasabach-Merritt phenomenon is a severe thrombocytopenia resulting from platelet trapping within the vascular tumor, and it is a life-threatening condition. So we move to face syndrome. So face syndrome, it actually associates with head, face, and neck large segmental hemangioma, and the face is actually it indicates posterior fossa structural brain abnormalities. It means that this large segmental hemangioma at head, face, and neck may associate with posterior fossa structural brain abnormalities, such as any malformation of cerebellar vernis or large cysts in the fourth ventricle of brain. Then A is arterial lesion, such as aneurysm or stroke, cardiac anomalies such as coarctation of aorta and eye abnormalities, such as strabismus and others. So there is definite and possible face criteria that we can use to determine is this a definite face or possible face. Next is pelvis syndrome. Pelvis syndrome is large segmental hemangioma that occurs at perineum. It may associate with external genitalia malformation such as hypospadia, micropenis, or penile the third for the L is lipomyelomeniingocele. It is a birth defect of child backbone as there is fatty mass at the back of the body of the patient. This mass will attach to spinal cord and pull it downward, and it will cause several symptoms. The V is vesicorenal abnormalities such as vesical urethral reflux or imperforated anus. And for skin text is painless, non-cancerous skin growth on skin, and it is connected to skin by stalk called peduncle. So this is the picture of Kasabach-Merritt phenomenon. So you can see the typical purplish discoloration. It is a very critical condition as it is life-threatening. Okay, so next we move to complication of visceral hemangioma, such as commonly occur at the liver, which is called infantile hepatic hemangioma. Infantile hepatic hemangioma are dangerous because 15% of it are complicated with cardiac congestive heart failure. So how does this hemangioma at liver cause congestive heart failure? Because it will create arteriovenous shunting. So this arteriovenous shunting will reduce systemic flow and will increase pulmonary blood volume as more blood from the systemic will return to the vena cava. So this will cause as the systemic blood flow reduce, this will cause the heart to work more and increase cardiac output, which eventually will result in cardiac congestive heart failure in infants. So then we move to investigation. In clinical setting, actually almost 95% of diagnosis is made based on history and the physical examination, and pediatricians are very expert at determining hemangioma only by history and looking at the mass because it is very typical appearing vascular tumor, and because of the history of lesion seen at birth or shortly after birth with the characterized by proliferation at early infancy. So then we move, but if we are confused or we cannot make the diagnosis from merely history and examine and physical, we can make we can do laboratory investigation, such as marker of hemangioma proliferation and differentiation, such as the serum vascular endothelial growth factor, urinary beta fibrillase growth factor, and also matrix metalloproteinase. And also we can also do platelet count in case of Kasabach-Merritt phenomena, and we will and in this case the platelet count will be reduced. There will be thrombocytopenia because it is trapped. Then we can do biopsy and excision, such as histopathological examination, in which I will show you the results later. We can also do routine immunohistochemical studies, and we can do tissue-specific immunohistochemical markers, GLUT1 or Lewis YAG. GLUT1 is very specific and very sensitive to hemangioma, and it is sensitive in both proliferative and also involutional phase. And lastly, we can do imaging studies such as MRI. In MRI, we will be able to detect the extension of the mass. We can also do ultrasound. In ultrasound, it will help us to differentiate between hemangioma and other subcutaneous structures such as lymph node, but it cannot locate the extension of the mass. Then we can do X-ray if we want, such as if we suspect the hemangioma affect the upper respiratory tract. So we can visualize that. Okay, so this picture shows the histopathological findings of hemangioma. So I just want you to appreciate at the proliferative and involution phase. So in the proliferation phase, you can see there is non-encapsulated masses and dense cord of microtically active plump endothelial cells and well-developed basement membranes and also presence of mast cells. Contrary, in involution phase, there is deposition of fibrofatty tissue, epidermal atrophy, scar tissue, and also loss of elastic tissue. Okay, so these are some of differential diagnoses. We can read it later. So next, we move to the management and treatment. So there are two types, as we discussed, there are two types of hemangioma, low risk and high risk. Majority of hemangioma are low risk. In this case, if it is low risk, such as small, did not cause any functional impairment, such as in eyes, and unlikely to leave permanent disfigurement. High risk hemangioma means it is large, prognostically poor location, such as at the eyes, or it affects the upper respiratory tract, or it likely to leave permanent disfigurement, or causing any functional impairment, or involving extracutaneous structures, such as in the liver. Or high-risk hemangioma also if it is large cutaneous or visceral hemangioma, because it can result in high output cardiac failure. So for management, most hemangiomas do not require treatment. For low-risk hemangioma, we just wait and watch. But it is very important for us to educate the parents, because some parents are very anxious, like, is my baby okay? So we must reassure the parents many times, like we say, this is only benign and it is okay, and it will regress, and by 5th year mostly. And other treatment, it is indicated for high risk complications, such as it involve vital organs such as heart and lung, or it will cause any disfigurement. So for the management and treatment, the first line is propranolol. So you can read the dosage, but propranolol may cause some side effects such as hypotension, bradycardia, and others. If propranolol cannot be tolerated by the infants, we may give systemic corticosteroids such as prednisolone. We can also give intralesional corticosteroid for small bowel spatial hemangioma. However, this intralesional corticosteroid must be done by very expert pediatrician. Then we also can, if the patient cannot tolerate systemic corticosteroid, we can move to other systemic therapy such as interferon alpha. But interferon alpha known for, because it can cause neurotoxicity, so the patient may have side effects such as myalgia or spastic diplegia. We can also do surgical treatment if the benefit outweigh the risk. surgical treatment good to be done on peduncle-related hemangioma that can cause functional impairment, or we can also do this to repair any cosmetic deformity. And we can do this by laser surgery or any surgical incision. So the prognosis of hemangioma, most uncomplicated infantile hemangioma has good prognosis. However, even though it has good prognosis, it will leave skin changes such as pigmentation, telangiectasia, atrophy, fibrofatty tissue, redundant skin, or scarring. So these are my references. That's all from me. Thank you.
Okay, thank you, Hisham. Can you come back for the stages of the appearance, the slide of the sequence of the first 2 months and after that?
Wait.
Okay.
Sekejap.
Yes, you put here, yeah, the same slide.
Yes.
So you said early therapeutic intervention. What do you mean by that?
Oh, because if we suspect, if we detect that the hemangioma are high risk, such as it will cause any functional impairment, such as it is on the eye, or it is at beard, it will cause any upper respiratory tract. So if we want to do therapeutic intervention, we must do at the proliferation phase, because it will it will stop the proliferative phase. So it is the most optimal time to start the intervention.
Yeah, this is a very important, but be cautious. So you mean especially in suspected complicated case, like it is in the pathway of the vision, it can affect the vision, it can affect the respiratory tract like that, okay? So especially in suspected complication, yes? But what happens if some mother or father tell you we need to start the treatment even if it is superficial? What you are going to do?
Maybe we have. So the question is, the hemangioma is only superficial, but the parents want to do intervention. Is it right?
Like strawberry, yes, like strawberry,
Oh,
superficial.
so I think maybe we have to professionally tell and reassure the parents that like ma'am, this skin lesion is only benign, and yes, it will grow for some time, but then it will regress. So you don't have to be worried like that.
Yeah, this is the most important point during counseling. You must be clear and honest and sympathize. That's why ambition of the family or of the mother or father must be respected by trying not to antagonize. Usually in medicine, you are making scale about the benefit and the risk. Sometimes we may take the decision on the important point if we feel like that, but let us see what is going. If she insists, I may transfer her to the vascular surgeon to tell her actually what can it happen if he is using the laser or blade, what is the expected complication. That's why our job in medicine, you are starting now year 3, you have more than 1,000 days to build up your future, to give benefit to your community and to your ummah also. So you must be start professional, try to know most of the detail, try to know how to discuss with the family, give them true knowledge. The mother Don't worry, mom, it is small. We suspect in most of the cases. Don't tell her your baby will get that sequence. In most of the patient, we used to find it enlarged until the age of 8 months. Then it will gradually decrease like that. We are suspected some complication, blah, 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 blah. So we must take care. So you are not going to be only a doctor who is prescribing medication or doing operation. You must be a good human who is able to give the knowledge, to sympathize the patient, to help them to get the correct decision on the correct time. Okay? Any question about hemangioma? Okay, if you don't have any question, we can go for the second presentation. I would like to ask now how many students are attending, because now I can find that the number is 35, including me. Is there anyone absent from the group, or you are using or you are sharing screen together?
Currently there is 34 students, but we presenting separately.
Sorry, again?
Currently we have 34 participants, yes. But yeah, we are going to present separately.
So you are 34 students. The number,
yes.
The total number is 34 also, or how much is it?
It should be 36, doctor.
So all the 36 students are available now with us?
Unfortunately, no.
Okay, because anyone not will come within few minutes, you must inform our science officer about his absence, and they must be investigated why he didn't come, please.
Okay.
Okay. In the next presentation, if you didn't ask questions, I will ask you, so be alert. I can ask any one of you. Okay. Let's go now for Husna and atopic dermatitis.
Okay, thank you Hisham for the presentation. Assalamualaikum warahmatullahi wabarakatuh. I bid to doctor and my fellow friends. So I'm going to continue our presentation with the atopic dermatitis, or also called as the eczema. So this is my presentation outline. We are going to present about the 10 components of eczema. So for the first one is the introduction. So what is ectopic dermatitis or the eczema? So ectopic dermatitis is defined as a chronic inflammatory itchy skin condition that usually develops in early childhood and follows a remitting and relapsing course. So usually the onset is early childhood between 1 to 2 years old, and 75% of them resolve at the age of 16 years old. But then some of patients persist until the adulthood. So in atopic dermatitis, it leads to the breakdown of the skin barrier, making the skin susceptible to the triggering factors. So the main problem in the ectopic dermatitis is actually the defective skin barrier function. So that I'm going to discuss further after this. So usually patients have the genetic components. For example, their family has history of atopic disorders such as the eczema itself, asthma or the hay fever. So we have a term called atopic march or the allergic march. So what is that? It is eczema is known to be one of the earliest allergic conditions that occur in the infants and young children. Before later in their life, they develop other atopic disorders such as the food allergy, the rhinitis, and the asthma. Why this happen? Some literatures mention because they have similar risk factors, but then this is not a simple progression, and it is strongly influenced by the genetic components and environmental factors. Second is the epidemiology. So globally, around 15 to 20% people worldwide are affected by the eczema. But according to the Allergy Center Malaysia, there is around 20% of Malaysian population is affected by the eczema, and male is more commonly affected by the females. So the highest percentage of the patients are from the Malays, which is the 69%, followed by the Chinese, Indians, and some of them are from the Punjabi. The median age of the patients is 74 months. This is around 6 years. And the median age of the diagnosis is 22 months, which is 1 year and 10 months. Okay. For the etiology, it can be divided into 3, which is the genetic predisposition, the triggering factors, and also the immunologic abnormalities. But then all of these are interrelated. The most important one is the mutations in the filaggrin gene family, which is the genetic predisposition, because filaggrin is actually a protein in our skin layer that give protective function to our body. So we know that skin should act as a barrier to the allergens from the infection and so on. So the filaggrin and its breakdown products is important for the skin barrier function. So we have triggering factors. The most common one is the irritations. For example, the house dust mites, the animal dangers, like the cats, the dogs, and yeah. So the physical irritants such as the nylon, the wool, the detergents, and even the sweating. So the environmental factors, which is the very extreme hot weather or cold weather, can also contribute to the ectopic dermatitis. So and then the microbes such as the Staphylococcus aureus, stress and anxiety, and even some foods, for example, the egg, soya, nuts, and fish. And then the immunologic abnormalities, this leads to type 1 hypersensitivity reaction. Other than that, cytokines found in the inflammation such as interleukin 4, 13, 22, 25, and TNF-alpha reduce the filaggrin expression. So how this happen? The first one is the genetic predisposition. The filaggrin mutations lead to the epidermal barrier dysfunction. So the skin become dry and cracked. So that's why this allows the entry of the antigens and initiates the production of inflammatory cytokines and inflammation process. So we can see the erythemas, or redness and swelling at the affected site, and the itchiness due to the histamine release. For the triggering factors, the use of detergents are neutral or alkaline. It can change the pH of our skin, the patient's skin, because the pH of our skin is actually slightly acidic, which is around 5.5. Yeah. And the hot weather cause excess transepidermal water loss, causing the dryness of the skin. And the cold weather, which has low air humidity, also cause the dryness of the skin. The microbes decrease the epidermal entry microbial peptides and the tight junctions. So this is important for the skin barrier functions. Some foods cause defects in the serine peptidase inhibitor, casal type 5. So this is also a protein like filaggrin in our skin layer that contribute to the skin barrier function. So stress also induce release of inflammatory mediators. Okay, for type 1 hypersensitivity, it has two phases, which is the sensitization phase and the activation phase. So repeated exposure to the allergens is important because we need the switching of IgE and the desensitization of the mast cells by the allergen. So these eventually lead to the degranulation of mast cells, releasing the histamine that is responsible for the itchiness, interleukin 4 that activates the B cells. So the activated B cells cause the stimulation of IgE class switching and thus increase the production of the IgE. Interleukin 5 recruit eosinophils, interleukin 6 and TNF-alpha is responsible for the inflammation, and some chemotactic factors such as CCL27 and protein 4 recruit more eosinophils. Okay, then we move to the clinical manifestations. The cardinal features of eczema is two, which is the intense pruritus, especially at night, and the cutaneous reactivity. The key features is actually the itchiness, because if it is not itchy, then it is not an eczema. So in eczema, we have three stages, which is the acute stage, the subacute stage, and also the chronic stage. So in acute stage, the characteristic lesion is intensely pruritic with the erythematous papule, like in this picture. In subacute stage, this is actually similar to the acute stage with scalene papules. So you can differentiate. There is some sort of scales or hyperkeratosis on the skin, and then the chronic stage is characterized by the presence of lichenification. So lichenification is actually the prominent skin lines due to the thickening of the epidermis, and this is usually found in the older lesions. So apart from that, there is also fibrotic papules in the chronic stage. But then in chronic stage, these three lesions can occur in same individuals. So eczema, the distribution is actually vary with the age of patients. For example, in infants, it typically affects the face, the extensor surface of the limbs, but then trunk might be affected, but napkin area is typically spared. So this is some sort of clue to us. Okay, next is the children who is 1 to 2 years old and onwards. It mainly affects the flexural surface, which is the antecubital and popliteal foci. And in some patients, if it persists to the adulthood, the locations could be in the flexural surface, at the neck, the wrist, ankles, eyelids, upper trunk, shoulders, and scalp. Okay, how we diagnose eczema according to the Clinical Practice Guidelines 2018. We diagnose eczema by using the UK Working Party's diagnostic criteria. So the patient must have an itchy skin, or even the parents can report that the child is scratching or rubbing certain parts of the body, plus 3 or more of the following. So the first one is the history of involvement of skin crease, such as at the folds of elbows, behind the knees, fronts of ankles, or around neck, including cheeks in the children under 10. The personal history of asthma or hay fever, or history of atopic disease in the first degree relative in children under 4. Also, if the patient has the history of dry skin in the last year, and then if the patient has the onset of the disease under the age of 2, and visible flexural eczema.
Which one is the more diagnostic of these three? Any three? Or there is some point to have an important in the diagnosis?
Sorry, Doctor?
You put now there is itchy and 5, yes, 5 criteria. You need to put 3 of it. They are in the same weight?
Yeah.
This
Yes,
5,
yes.
all of them are on the same way.
Yes.
Okay.
Okay. Okay, this is from the pediatrics protocol for Malaysian hospital, the Hannifin and Rajka criteria. So it has the major features and the less specific features. So how to diagnose? The patient have 3 out of 4 of the major features. So, but then we tend to follow the CPG because this is approved by the Ministry of Health in 2018. Okay, for the differential diagnosis, there is a long list of differential diagnosis of ectopic dermatitis, but then I want to emphasize only 4, which is the seborrheic dermatitis, the allergic contact dermatitis, the psoriasis, and the nickel dermatitis. So the seborrheic dermatitis is the most common differential diagnosis in infants, So the lesions are well-defined borders with the scales is thicker and greasy in yellow, which typically involve the scalp, or we also call as the cradle cap, like in this picture. The eyebrow, the perinasal region, the upper chest, and also at the back. But how we differentiate seborrheic dermatitis with eczema? Seborrheic dermatitis has little or no pruritus. Second is allergic contact dermatitis. So from the name itself, we know that the patient have allergic to something. For example, the rubber shoes, the moisturizer, and then the soaps, and so on. So actually, it's difficult to differentiate allergic contact dermatitis with the eczema, but then the distribution limited to one area of the body suggests the diagnosis, because the area is the one that contact with the allergens. So the shapes of the lesions correspond to the source, so that's why they can be in bizarre shape, linear, square, and angulated shapes. Third one is the psoriasis. In contrast to the eczema, it involves the napkin area with the well-demarcated lesions, oval or round in shape, and the thick plaques. The lesions is in salmon color at the base with an overlying hyperkeratosis with the silver coloration. So like in this picture. So it is localized on the elbow, on the knees, at the lower back, and also at the scalp. And the last one is the nickel dermatitis. So we know this is due to the contact sensitization to the nickel in metal. So that's why the locations is at the area where the patients might be contact with the nickel. So from for example, in this picture, this pen buttons has the nickel in the metal. So that's why patients have the lesions very umbilical. So in the yellow, if the earring have the nickel, neck if the necklace have the nickel, and also the underrings or the wristband. So this is a long list of atopic dermatitis. We have other types of dermatitis. We have infectious skin diseases, which is the scabies that will be explained by my colleague after this. And then we have also congenital immunodeficiencies, nutritional deficiency, and metabolic disorder, and also neoplastic disease. So I hope you can read later on. Okay. So how to investigate? Similar to the previous one.
It is better to speak about the last slide, please, even 1 or 2 minutes, just to orient your colleague about not all rash, even with itching, is equal to dermatitis. Yes, come. No. This one, which is immune deficiency, yes. Congenital immune deficiency and the nutritional one.
Oh, okay. For the congenital immunodeficiency, we have the ichthyosis vulgaris. This is uncommon. This is a dry skin with the fine scaling, particularly on the lower abdomen and the extensor area, the perifollicular skin roughening, and palmar hyperlinearity. And then it can also be caused by the zinc deficiency, but this is also uncommon with the erythematous scaly patches and plaques, most often around the mouth and the anus. And then we also have the biotin deficiency, the pellagra, and the kwashiorkor. So the kwashiorkor is has the flaky, scaly dermatitis with the swollen limbs with cracked peeling patches. And yeah, the neoplastic disease such as the Langerhans histiocytosis, this is characterized by the hemorrhagic and the peticle lesions. Yeah, okay.
You see here, you can find in this histiocytosis X, Langerhans histiocytosis, there is scaly and berberic dermatitis. Okay, still you can accept as eczema now or dermatitis, but you must examine for hepatosplenomegaly. If you find hepatosplenomegaly, okay, or cytopenia, the full blood count started to be affected, so it can guide you, because sometimes you are able to pick, as my inshallah comment on the end, many dangerous or many systemic disease by the skin. Okay, continue, Husna.
Okay, thank you, Doctor. Okay, for investigation, first and foremost, we do not diagnose eczema based on the laboratory investigations. This is mainly due on the history and the clinical features of the disease. So, but then there is certain tests that we can do to support our diagnosis. For example, we do the blood test because 80% of patients has elevated IgE and the peripheral blood eosinophilia, even though this is not specific. And then we also have the skin prick test to identify the allergens and the radio oligosorbent test or the RAS. Rather than identifying the allergens, we identify the IgE that is specific to the allergen. But again, the diagnosis is made clinically and not by any specific laboratory investigations. The complications, the most common one is increased susceptibility to secondary infection because of the defective skin barrier function. The most common one is the Staphylococcus aureus, followed by the Streptococcus pyogenes. Some viruses, such as the herpes simplex virus, can cause the eczema hepaticum, the virus, and molluscum contagiosum. So in this picture, you can see the ectopic dermatitis with Staphylococcus superinfection and the eczema hepaticum due to the HSV. Okay. Ocular complications can also occur, such as the conjunctival irritations, but the less common one is the keratoconjunctivitis and the cataract. The regional lymphadenopathy can also occur, but it is often in the active eczema and resolve when the skin improve. So remember that this disease does not only affect the patients physically, but it has also the psychosocial impact to the patients and even to the parents. So the patients may be embarrassed due to the disfigurement, lack of sleep from the pruritus, because I mentioned before, the intense pruritus usually occur at night. So this can cause stretching and resulting in irritability and the fatigue. And also the financial strain due to the hospital visits and the medications. Okay, the last one is the management. This is also from the CPG. Okay, first and foremost, we assess the severity and quality of life of the patients. So the preferred tool is the investigator's global assessment, the IGA. So it has score 0 to 5, where the 0 is no inflammatory signs of atopic dermatitis. 1 is the just perceptible erythema and just perceptible population. Score 2, it become a mild, and then 3, it become moderate. 4 severe and 5 severe erythema and severe population with the oozing and crusting. So remember that the severity assessment should be included in our management. After the severity assessment, we plan what the therapy should be given for the patients. So for the therapy or the treatment, we have the pharmacological treatment and non-pharmacological treatment. For pharmacological treatment, we have the topical therapy and the systemic therapy. Okay, the first one is the topical therapy. We have the emollient or the moisturizer. We also have the topical corticosteroid, topical calcineurin inhibitors, and also antimicrobial. So the emollient is the first line and remains as the mainstay of the management. So how it works, it improves the barrier function and the dryness. So it reduces the pruritus, and it has various formulations. It can come in form of ointments, creams, lotions, and gel. But then there is no clinical evidence that shows that one emollient is superior to one another. So generally, this is safe and reduce the usage of the topical corticosteroid. So for topical corticosteroid, this is the first line for anti-inflammatory. It should be monitored every 3 to 6 months to see the potential side effects and the response. It is divided into class 1, 2, 3, and 4 according to the potency of the drugs. So the choice depends on the age, site, chronicity, and the severity of the inflammation. So for example, we have the clobetasol propionate, the hydrocortisone acetate. So this the drugs should be discontinued gradually to avoid rebound. For example, twice daily and then become once daily and then 1 to 3 times per week before the complete discontinuation. Okay, topical calcineurin inhibitors. This is to treat the flash, which is the severe form of the eczema. But then it's only licensed for children above than 2 years old because we want to avoid the adverse drug reaction. For example, tacrolimus and pimecrolimus. For antimicrobial, the routine use is not recommended and only used with the clinical evidence of the infections. The short-term use for VP lesions. VP lesions is the pus field distress. The long-term should be avoided, and the example is potassium permanganate and chlorhexidine. Okay, the systemic therapy, it can be the adjunctive treatment or the specific treatment. The antihistamine is the adjunctive treatment. A dose before time really helps because it improves sleepless due to the stretching during at night. Okay, and the immunomodulating agents is only being used in the severe cases, meaning that the other options have failed or the patient have significant impact on the quality of life. So we have this cyclosporin A, methotrexate, IV immunoglobulin, and interferon gamma. That's it for the pharmacological treatment. This is non-pharmacological treatment, which is the educational intervention. So remember that the patient's understanding and even the caregiver's understanding is very important for the self-management of the eczema. So we have the written eczema action plan, WEAP. We have the, it is divided into 3 subgroups according to the color coded. We have the green, yellow, and red. So for every color code, it has its own suggested therapy or the advice that should be done by the patients and the caregivers. For example, green, which is the eczema under control, they have the regular daily skin. They have to take bath twice. They apply the moisturizer. They wear pajamas that is suitable before sleep. And then we have the yellow. This is when the eczema is worsening. So still we continue the green phase that is mentioned here, plus anti-inflammatory creams, antihistamine. But then if the eczema gets better, we revert back to the green phase. But if the eczema is not responding within 3 days of eczema and it worsens, we move to the red phase. So in the red phase, we still continue the green phase and then anti-inflammatory, antihistamine. But then if the eczema gets better, similar to the yellow one, we revert to the previous class and subsequently to the green phase. But it is not responding, so consult the doctors. So referral to dermatologist is recommended in some conditions. Okay. This is the summary of what the management of the atopic dermatitis. We have the algorithm to treat the atopic eczema that includes the IGA score, the severity, the planning therapy, and also the educational interventions. Okay, this is my references and that remarks of my end of presentation.
Okay, thank you for AD, atopic dermatitis, which is autosomal, not autosomal dominant. Anyone have a question?
I have a question.
Yes.
Since you say that this atopic dermatitis is the diagnosis of atopic dermatitis is made clinically, what is the significance of having extra investigation? Why there is an investigation need to be made?
Yeah,
Oh,
it is.
okay.
Yes. Can you answer, Husna?
It's okay, Doctor. You can.
Go ahead. But
Oh, okay.
I happy
As
to hear from any one of you.
Okay. As I mentioned earlier, this investigation is only to support our diagnosis. This is not to the definite criteria to diagnose the eczema. So because in the blood test, 80% of patients has elevated IgE and the peripheral blood eosinophilia, but then this is not specific. That's why I emphasize back that the diagnosis is made clinically and not by any specific investigations. Is that answering your questions?
No, I think this is sometime, Yasin, if you are thinking about that, we need to give the family some, what is this, some knowledge, okay, that if we find, as she said, elevated IgE, in spite if it is not specific, but it goes with that one. But the most important, if we do the Rust test, it will identify the allergens which must be avoided. So it will help in the diagnosis. I mean, if I did it, they will put for you a big and list of food which you must avoid and the contacts and like that. So it will help us to avoid this one, which give a good achievement. So it is very important. In spite, it is not required for diagnosis, but it can support and it can help in the treatment. And sometimes remember in our, it is a good question really, because some we may think about concrete thinking. So don't touch the patient, don't do investigation. It may be, I'm afraid that this child has a super added viral or bacterial infection. I would like to do full blood count. When I see, I will find eosinophils are very high. So it goes with it. Beside, there is infection. Another point, like there is some investigation of exclusion. It is not typical for eczema or atopic dermatitis. Like if you are speaking about one of the common disease like Henochilan purpura, like this, it is a diagnosis of exclusion. I mean, I am going to exclude other, which can be ITB, which can be another cases. If it is not the one, it will be Henochilan purpura. So you need sometimes to think about the investigation, not as a routine, either for confirming partially the diagnosis. It helps you to rule out another diagnosis. As I told you, if you are going to speak about histocell histiocytosis, it is very dangerous and they need to be diagnosed. If you find that, even by simple investigation, we can try to diagnose it. So to rule out another diagnosis or another complication or another preventive medicine in that situation. Okay. That's to mean you must have rationale for any investigation, but you mustn't be very restrictive. No, it will guide you. Any other question? Okay, so let's go for the third presentation, because I need to start my round about 7. Okay.
Can you see the slide?
Yes.
Yes.
Okay. Thank you. Assalamualaikum warahmatullahi wabarakatuh. I will be presenting about scabies. This is my outline throughout this presentation. So this is scabies. Scabies is caused by the organism which named Sarcoptes scabiei hominis. It is one of the parasitic mites which infest under the skin of the human at the level of the stratum corneum, which is the outermost layer of the skin. And you can see in the picture, that is the picture of the organism. We go to the epidemiology, and in the worldwide, the overall prevalence of this scabies infestation in multiple literature is around, it can be 0.2% to 71%. The 71%, especially in India, especially in the poor tropical country, overcrowded, overpopulation country, there will be high prevalence of these cases. In the poor tropical countries also, the average prevalence in children is around 5 to 10%, which is a lot. It is endemic in many resource-poor tropical regions, more common in young children and elderly, and the recurrent infestation is common. While in Malaysia, which I take from the study done at the welfare home in Penang, which take around 120 samples, which is, I think, not adequate, but it is enough to know that in Malaysia, there is high prevalence of scabies cases, which is overall prevalent rate is 31%. It is highest among age 10 to 12 years old. The more common in boys, which is 50%, and girls 16%. This is a very limited studies, but it can show us in Malaysia is a warm and tropical countries, which is the favorable habitat for these Sarcoptes scabiei to live and multiply. For the etiology, the scabies caused by burrowing and release of toxic or antigenic substances by the female mites, Sarcoptes scabiei hominis. And adult female mites measure approximately 0.4 mm in length, has 4 sets of legs, which is 8 legs, and has a hemispheric body marked by the transverse corrugation, brown spine and bristles, which is contribute to the itchiness of the skin. The mode of transmission is human-to-human contact, sharing bed and sharing clothes. Children and sexual partners of the affected individual are most at risk. The life cycle, there is a long list of the life cycle, which I will simplify it in a simple word. The first, we must know that there is 4 stages of this organism life cycle, which is the first one, egg, larva, nymph, and adult. The female Sarcoptes scabiei will deposit 2 to 3 eggs per day as they burrow under the skin. And why I say about the burrow, it is about the permanent home. And later I will explain about there is molting pouches, which in the simple word, I call it a temporary home. Okay, the female adult mites will lay eggs in the permanent home, which we call burrows. This burrows is located at the outermost layer of the skin, which we call stratum corneum, the outermost layer of the skin, and never below that. It's only at the level of the stratum corneum. Okay, in the permanent homes, the burrows, the female will lay eggs, 2 to 3 eggs per day. The egg will hatches and will release larva. The larva will climb to the surface of the skin and form a temporary home, which we call molting pouches. In this temporary home, the larva will mature, or will molt, in other words, will molt into nymph, and the nymph will molt into the adult. And in adult stage, this organism is ready for mating session. The female adult of Sarcoptes scabiei will wait for the male Sarcoptes scabiei to impregnate it. The impregnated female will leave the temporary home, the molting pouches, and find the permanent and make the permanent burrows, which she will live for the rest of her life, which is 1 to 2 months. And we can see the life cycle of this Sarcoptes scabiei is around 1 to 2 months. So if we take in 2 months, which they will lay eggs 2 to 3 eggs per day. It means it's around in along its life cycle, it will lay around 120 eggs along its life cycle. So the clinical manifestation of these scabies, it will appear from the first infestation until 2 to 6 weeks. There will be appeared symptom at the person body. There are two type of scabies mainly, which is the first one is classical scabies, and the second one is crusted scabies. The host for the classical scabies is immunocompetent, a normal person like us. And the difference between classical and scabies is classical scabies and crusted scabies. The host is immunocompromised and elderly patient. Immunocompromised including HIV, transplant patient, or in prolonged use of corticosteroid, prolonged chemotherapy, which include in the immunocompromised patient. And in the classical scabies, the pruritus will severe and worsening at night, whereas in crusted scabies, there will no or minimal pruritus. For the cutaneous lesion on the classical scabies, there are multiple small erythematous papules and often associated. But on the crusted scabies, it is poorly defined erythematous patches that quickly develop into prominent scale. The scale become warty, especially over bony prominence. Crust and features will appear. The lesions are malodorous, very smelly, and the nails are often thickened, discolored, and dystrophic. It is because there are thousands or millions of these subcutis scabies on the patient's skin because the patient is immunocompromised. So the organism will multiply very rapidly. So you can see thousands or even millions of these organisms on this patient for the crusted scabies. For the classic scabies, in infants will often have a diffuse eczematous eruption that will involve scalp, neck, and face, while in crusted scabies, they will often accompanied by generalized lymphadenopathy and eosinophilia. As you can see, this is the image of the classical scabies. The first picture we show the scabies bureau. There is a linear lesion on the skin, which indicate which burrows made by the female mites. You can see there is nodular scabies, vesiculopustular lesion on the lateral side of the hand, and you can also appreciate the pruritus. The next is, this is the image of the crusted scabies. We present, there is a hyperkeratosis and crusting at the gluteal cleft and fold, and you can see the crusted scabies on the extensor surface of the elbow, secondarily infected with Staph aureus. And you can see the hand of the patient. There is hyperkeratosis at the palm of the patient. And you need to be noted that this scabies favorable place is between the skin fold, which is, for example, is between the fingers, the axilla, the buttock, the area of the breast, at the neck. So this is the favorable habitat for these scabies, for these subcutis scabies. I bring you the case report. The example of the case report, which is a girl aged 11 years old came with her mother with chief complaint of full body itchiness since 2 weeks ago. According to her mother, its itchiness started from her fingers, which is a very common site for the subcutis scabies to go first, which widespread in more numbers and different size to her waist, armpits, and back within the time frame of 1 week. She also complained of itchiness in her lower extremities, itchiness which is the major clinical manifestation of this infestation, which mainly appear in between her toes and knees. The girl experienced such for the first time and had never consulted to a doctor before assuming it would disappear by itself. Furthermore, she said that the itchiness worsened at night, which is this is the symptom mostly exhibited by the classical scabies. And her sleep was ruined by the intense pruritus for the past 2 weeks. In these 2 weeks, the complaint did not reduce or subside. It intensified until her daily routine was affected. History of pyrexia was denied. It was denied maybe because of no secondary infection, no secondary bacterial infection. In scabies cases, there will be complication that will lead to the secondary bacterial infection, such as Staph aureus and also beta hemolytic streptococci. Her mother applied a traditional cream to affect the area, but the symptom did not show any improvement. According to girl, currently both her brother are experiencing the same complaint. Apparently, she has a history of sharing the same room and bed with both her brothers, which is she got the infestation from her brothers by sharing the same bed with her brothers. Upon the physical examination, the patient was alert, appeared well nourished. The BP was normal, respiratory rate was normal, pulse and body temperature was normal, no mencephaly, no anemia, no icterus, ear, nose, throat are normal, no palpable lymph node at the neck region. Other examination appear normal. Upon the dermatological findings, the itchiness at the bilateral between finger, wrist, palm, armpit, back, and chest, multiple erythematous papules, multiple spherical papules, and a few serpiginous papules on right hand, straight light, elevated light, whitish to grayish in color. The diagnosis is clinically with scabies. So how you want to diagnose the scabies? The first, there is 4 points to diagnose scabies. First one is the type of the lesion. The second one, the site of involvement. The third is symptom. And the fourth is other members such as itching, which take approximately 4 to 6 weeks to develop in other part of the body. The diagnosis can often be made clinically, but it can confirm by the microscopic identification of the mites, ova, and the scabula in the epithelial debris. So how you want to perform this is by scraping method. The doctor will use a drop of mineral oil on the selected lesion and scrape it with a number 15 blade. Number 15 blade is a blade, is a surgical blade which used to make a small and precise incision, but we will not make an incision here. We just scrape it and transferring the oil and the scraping into the glass slide. And you will see for the picture A, there will be human scabies mite obtained from the scabies, from the scraping, which will be the scabies ova, which is the scabies 8, and the scabies scabula, the scabies feces, seen under the microscope. Dermatoscopy and the digital photography are non-invasive and effective method for identifying the presence of the scabies mite, which is, this is the example of the dermatoscopy. The differential diagnosis is made by there is a lot of differential diagnosis that can be made according to the clinical manifestation. For the papula vesicular lesion, you can see the papula urticaria, canine scabies, chickenpox. For the segmental lesion, you can see the ectopic dermatitis, seborrheic dermatitis. For the nodular scabies, you can see the urticaria pigmentosa and the Langerhans cell histiocytosis. For the complication, there is secondary bacterial infection due to the Staph aureus or beta hemolytic streptococci. This complication due to injury by scratching. So to the infection to skin area due to scratching of itchy skin. If severe, it can cause post-streptococcal glomerulonephritis or sepsis. The second one is pyoderma, which is painful sores on the skin. For the management, for the classical scabies, for the infants less than 2 months, the recommended therapy is sulfur 6% in petroleum in ointment base for 3 days. it must apply to the whole body, including the face, but avoid the eyes and the mouth. And you must note that the sulfur 6%, the sulfur therapy is malodorous, which is the smell, the intense smell. The smell is very bad. And it is recommended to treat all the family members close contact simultaneously. For the children under 2 years, 2 application of permethrin 5% for 8 to 12 hours at 1 week apart. For the alternative therapy, it can also apply the sulfur 6%. For the children less than 12 years old, also the same 2 application of permethrin 5% for 8 to 12 hours at 1 week apart. For the alternative therapy, you can use a benzyl benzoate 12.5% for the whole, which apply the whole body, neck, and below for the 3 consecutive days. For the Linden lotion, 1% lotion also available, but this cream should be only used as an alternative therapy given it risk of systemic toxicity. For the management of crusted scabies, the recommended management is permethrin and ivermectin simultaneously. Oral ivermectin alone or in combination with permethrin is very useful. Or you can use the benzyl benzoate also. For the secondary bacterial infection, you can use the systemic antibiotics, which cover gram-positive organism at least for 7 days. It can be started concurrently with scabicide or delay for 48 hours. Use antiseptic soap bath in pathogenized scabies, which is in scabies that have impetigo due to the secondary bacterial infection. For the itchiness, you can use antihistamine, corticosteroid, and emollients. This is more like of prevention. After the completion of the treatment, the patient should use fresh, clean bedding and clothing. The contaminated clothes and bedding should be washed at the high temperature water or keep in sealed plastic bag for up to 72 hours to stuff the mine. The patient with scabies and their close physical contacts, even without symptoms, should receive treatment at the same time. Prescription must be provided for all household members and sexual partners. There are also methods which you iron the clothes, but ironing the clothes only are not as effective as wash the clothes at the high temperature, because there will be a part that not covered by the iron. This is resource for my presentation. That's all. Do you have any question?
No questions? Okay, so don't forget that the scabies prevalence may be less than 1 up to 70%. And it is suspected in some area to be around 30 around us. So don't miss it, especially if it is early. That's why the history from the family of other member, sharing clothes, poor situation, okay, are very important during taking history. And don't forget now, you need to convince the family to be treated, all the family, which is not simple. We need all of you to be treated. At the same time, you need to help them how to do prevention. I mean, they need to trim the nails. They need to even ironing the clothes, even the internal one. Okay, not sharing clothes with everyone. This is an important and very effective way to cut the cycle of scabies, which can be difficult to attack after that. Okay. the dangers of doing closes without completely sterilization and ironing and good wash and ironing. We must take care about that. So it is better if anyone need to do donation for his clothes, just to make complete preparation with antiseptic, with washing, with ironing. Otherwise, some people are good resistant. They have mild scabies, but they may infect others. Okay. And remember, this sharing clothes can also cause some sort of tinea and like that. Okay. Thank you, Luqman. Let's go for the last presentation.
Assalamualaikum. Can you hear me?
Yes.
Hold on, I'm sorry. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Akilah. Inshallah, I'll be presenting on the last part of this presentation, which is the Stevens-Johnson syndrome. Okay, so these are the contents of my presentation. So I'll be presenting on the introduction and the prognosis of the Stevens-Johnson syndrome. Okay, so basically Stevens-Johnson syndrome is a systemic disease that is due to the reaction of the hypersensitivity type 4 immune reaction. Okay, so based on the pediatric protocols, Stevens-Johnson syndrome or SJS is referred to as severe erosions of at least 2 mucosal surfaces with extensive necrosis of lips, mouth, and also purulent conjunctivitis. Okay, and then over here, I also put the toxic epidermal necrolysis, which is a severe exfoliative disease associated with systemic reaction characterized by rapid onset of widespread erythema and epidermal necrolysis. Okay, so why is the TEN is being put here is because TEN is the severe form of SJS. Okay, and as you can see in the picture, that is the picture of necrosis of lips and mouth, and then the purulent conjunctivitis that is seen in SJS, and then in TEN we can see a widespread of erythema and also epidermal necrolysis, and both SJS and TEN are sometimes being referred to epidermal necrolysis. Okay, so this is the classification. So as I've said before, SJS and TEN are considered a disease continuum, and they are distinguished chiefly by severity based upon the percentage of the body surface area that is affected by blisters and erosions or detachment of the skin of the body surface area. Okay, so the first one, we can see the SJS, which involves less than 10% detachment of the body surface area. And then we also have SJS and TEN overlap, which involve 10 to 30% of the body surface area detachment. And then for TEN, it involves the detachment of more than 30% body surface area, where we get the detachment which is like blisters and also erosions of the skin. Okay, so next is the epidemiology of SJS and TEN. So worldwide, the incidence of SJS and TEN is estimated to happen in 2 to 7 cases per million people per year. And then the occurrence of SJS is 3 times more likely than TEN. Okay, so in terms of gender, SJS and TEN is more common in women compared to male, and the ratio of women to men is 2 to 1 ratio. Okay, and as for the age, it can occur at any age, but typical onset reported is under the age of 30 years old. But there are cases that has been reported in children as young as 3 months and adult as old as 78 years old. Okay, so people who is immunocompromised, and particularly of those patients of HIV, they are more likely to get SJS or TEN, because there is estimated incidence of 1 cases of SJS in 1,000 cases of HIV patient. Okay, so these are the etiology of SJS, TEN, and medications is the leader trigger of HS type 4 in SJS or TEN occurrence. Okay, so basically the risk of SJS and TEN seems to be limited to the first 8 weeks of the treatment of when the medication is started. Okay, so which means that if the drugs is used longer than 8 weeks, though it may not be the causative agent of the SJS or TEN. Okay, so the medications involved are antibiotics, anticonvulsants, and also NSAIDs. So the one that I put star at the end is the most common causative agent of SJS. So in antibiotics, the most common one is sulfonamides, and then we also have amoxicillin, ampicillin, ethambutol, and isoniazid. For anticonvulsants, the most common is phenobarbital and also carbamazepine, and phenytoin can also predispose and also cause SJS TN. So NSAIDs such as the phenylbutazone and salicylates. For infections, for viral infection, there are herpes simplex virus, enterovirus, adenovirus, measles, and mumps. For bacterial infections, the most common causative bacteria or microorganism is the Streptococcus species, Salmonella typhi, and also Mycoplasma pneumoniae. So the second leading cause of infection, bacterial infection causative SJS, is the Mycoplasma pneumoniae after the Streptococcus species. Okay, other than medications and infections, the etiology of the SJS can be idiopathic, which account for about 1/3 of the cases of SJS is of an unknown etiology. Okay, so these are the risk factors for SJS and TEN. So basically, we can see here that more of it is the patient who are immunocompromised. So the first one is typically if the patient is having HIV infections, even though like the direct relation is fully understood between HIV and SJS, but then some studies say that it may be because HIV patient is predisposed or due to the multiple drug that is being consumed by them. Okay, and so it may increase their risk to get SJS due to drug. Okay, and then for malignancy, typically active malignancy and those of patient having cancer, the highest risk to get SJS is of those who is having hematological cancer. Okay, for genetic factors, the gene involved is the HLA genes of phenotype HLA-A and phenotype HLA-B. So most patient who is having this gene is predisposed to SJS. But there are studies that say that these findings is not applicable to those in Asian and also European population, but it can be related to other population when it comes to the gene factors of HLA genes relation to the SJS. And other factors that increase the risk of SJS is high dose medication, the medication that we have talked just now, like the carbamazepine and so on. Okay, and then patient who is having SLE and also who are being exposed to the UV radiotherapy. Okay, so now we're going to look at the pathogenesis. Okay, so there are no exact pathogenesis of how SJS occurred, but then it's all due to the HS type 4 reaction. Okay, so the causative agent or the etiology is just the drug infection, and then the risk factors of being immunodeficient, immunocompromised, and also the genetic predisposition may trigger the hypersensitivity type 4 immune reaction, whereby the HS cell mediated cytotoxicity reaction against the keratinocyte that will express the foreign antigen. So when the HS type 4 is triggered, then the patient will have the clinical manifestation of the prodrome. So they will be experienced with fever, malaise, and arthralgia 1 to 3 days prior to the eruption of rash. Okay, and then the HS type 4 will stimulate other mechanisms. The first one, so you can see the granulysin secretion by cytotoxic T lymphocyte and also NK cells. And then the drug-specific CD8 cytotoxic T cells expand and infiltrate into the dermoepidermal junction. And then the fast ligand of the tumor necrosis factor protein activated on the keratinocyte membranes, which will then induce the cell apoptosis. So these three mechanisms will then stimulate the massive keratinocytes apoptosis to the patient. Okay, so the patient will then experience prodromal rash, and so when there's the confluence of the lesion, then it will lead to the epidermal necrosis, which is the SDS, and also if it's progressed, it become a TAN. Okay, then HS type 4 also it gives a direct effect on the epithelium, where it will damage the epithelium, will causing the sloughing of the mucous membrane, and so the patient will experience target lesion, flaccid bullae, mucosal ulceration, cough, and also conjunctivitis. So next, we're going to look at the clinical manifestation. So the most common, which is the cutaneous lesion itself. It is typically begin with ill-defined calyzing erythema macules with purpuric centers. Okay, after this, I will show you the picture. Okay, the cutaneous lesion often tender and pain can be prominent. Okay, so the scalp is typically spared, and the palms and soles are rarely involved, but it can be involved, but rarely involved. The lesion starts from the face and trunk before it spreads to other extremities and peripherally. The atypical target lesions with darker centers may be present, and as this disease progresses, vesicles and bullae will form, and within days, the skin will begin to slough. Okay, and then the sign that related to the cutaneous lesion, the first one is Nikolsky sign, and Nikolsky sign may be positive in SDS patient. So how we check for Nikolsky sign is when there's the ability to extend the area of the superficial sloughing by applying gentle lateral pressure on the surface of the skin. Okay, and then the second one is the Esbo-Hansen sign. It is when we firm pressure on the bullae, and there will be a lateral extension of the bullae. And then the ultimate appearance of the skin has been likened to that of the extensive thermal injury. Okay, so the next clinical manifestation is the one we have said before, the prodrome. It begins 1 to 3 days before the eruption of rash, and the fever often more than 39 degrees Celsius, and the patient will have influenza-like symptoms together with malaise, myalgia, and arthralgia. They also may be experiencing photophobia, conjunctival itching or burning, and also dysphagia if there's involvement of the eye and also esophagus. Okay, and then for mucosal lesions, it occurs in approximately about 90% of the cases, where it either precedes or it's follow the skin eruption. Can happen before or after the skin eruption. So presented with painful crust and erosions. It may occur on any mucosal surface. Okay, for oral involvement, the oral mucosa and the vermilion border are almost involved with painful hemorrhage erosions covered with a grayish white membrane. And then they can also have stomatitis and mucositis, which lead to impaired oral intake. So due to the impaired oral intake, the patient may be malnutrition and also dehydration because they can't eat and also drink due to the affected lips and mouth. Okay, and then for clinical manifestation in the ocular side, it's happened in approximately 80% of the cases with severe conjunctivitis, with purulent discharge, and bullae may also develop in the ocular region. Okay, for corneal corneal ulceration is frequent, and anterior uveitis or panophthalmitis may occur. And pain and also photophobia are accompanying symptoms if it affects the ocular area. Okay, so the next one is urogenital. So urethritis may present in 2/3 of patients with SJS, and it may lead to urinary retention. And genital erosions are also frequently seen in SJS patients. So others affected site may be pharyngeal mucosa, and then trachea, bronchial and esophageal membranes, and also intestinal involvement may involve even the express. Okay, so we can see here the Nickel sign. So the skin is reddened, and under the skins there is seen a fluid collects underneath, and the skins will rubs off. And if we like move the skin a bit, and the skin is movable, and we can see like the raw red best under the moved skin, then it's a positive Mikulski sign. And as for the Espo-Hansen sign, if we like put a gentle press on the bulle and there's lateral expansion of the bulle, then it's a positive Espo-Hansen sign. Okay, and then the next one, we can see buccal mucosa involvement, target lesion, conjunctival infection, and also esophageal sloughing. Okay, so how do we diagnose SJS or TEN? So basically, there is no universally accepted diagnostic criteria, no there is any histologic findings that are specific or diagnostic of SJS itself. So the diagnosis is made solely based on the history and also physical examination findings. So upon history taking, a suggestive history of drug exposure or febrile illness. So the drug exposure commonly precedes the onset of the symptoms by 1 to 4 weeks, so in the average of 14 days. But then the re-exposure may result in onset of symptoms in as little as 48 hours. So re-exposure it means that they have been exposed before by the same drugs, and then they have their reactions, but then they take the drugs again. Okay, so the onset of the symptom is shorter compared to if the first exposure. Okay, so upon physical examination and also history, the prodrome of acute onset febrile illness and also malaise, a painful rash that progresses rapidly, erythematous macules, targeted lesions, or diffuse erythema progressing to vesicle and bulle. Okay, and then a positive Mikulski sign and or the positive Bulle-Hansen. And then oral, ocular, and or genital mucositis with painful mucosal erosions. And then there's we can also see a necrosis and sloughing of the epidermis of varying degree. Okay, if we sure that if we say that the SJS may be due to drug, then we need to do the assessment of drug causality, because the early withdrawal of the drug will improve the prognosis of the patient. And the assessment done based upon the detailed history and clinical judgment only based on the drug that we suspect it to be the causative agent of the SJS. Okay, so the investigation that we done, not to like make to the diagnosis, but to separate. The first one is the complete blood count, where we may expect anemia and lymphopenia, and uncommonly neutropenia, and also eosinophilia. And then we also do CRP and ESR, where it might be increased due to the inflammatory reaction. And then for liver function test, there will be like a slightly increase in transaminase and also hypoalbuminemia. Okay, since the patient may be loss of fluid, so we also need to take renal function test to check for the electrolyte imbalance, increase BUN, and also increase in glucose. Okay, so in this patient, there are risk of super infection and sepsis. So we need to get bacterial or fungal cultures, but usually we take it either from the blood or from the wound and the skin lesion itself to get culture. And then we also can do chest x-ray, because this patient, they are at higher risk of getting pneumonia and also interstitial pneumonitis. So the next investigation is skin biopsy. So skin biopsy is useful in confirming the diagnosis and also excluding other conditions that may mimic SGS and TEN. So the skin biopsy, we may do the routine HPE, and also, if possible, we can do direct immunofluorescence. But direct immunofluorescence will always be negative in SGS patient. Okay, so upon HPE, in early stages, there will be apoptotic keratinocytes scattered in the basal layer of the epidermis, and also perivascular mononuclear inflammatory infiltrate in the papillary dermis, which composed of primarily of the T lymphocytes. But then this infiltrate is not diagnostic. And as the lesions progress, we may see the frank subepidermal bullae that will develop and full thickness of epidermal necrosis. Okay, so this is the differential diagnosis of SJS that may mimic or may be confused with SJS. The first one is acute generalized axanthomatous pustulosis, or AGEP. So in the severe case of AGEP, it may be difficult to differentiate with SJS and TN. So, but AGEP typically develops within a few days of exposure to the offending drug, but then it will resolve without treatment in 1 to 2 weeks after the drug is discontinued. Okay, the second diagnosis is erythema multiforme. But it is like closely related to the HSV infection. It is usually present with typical target lesions or raised atypical target lesions that are predominantly located on the extremities. And the bullae and epidermal detachment in erythema multiforme usually limited and involve less than 10% of the body surface area. Okay, so the next DDX is the erythematous drug reaction. It is generalized and symmetric and presented with maculopapular erythema of a drug eruption pattern. And it can mimic early SJS or TEN. Okay, and the last one is staphylococcal scalded skin syndrome. Okay, usually happen in infants. So in SSSS, there will be sparing of mucous membrane and absence of risk factors for TEN, such as any offending drug. Okay, but then clinical suspicion of staphylococcal infection can give us like a view of the SSSS that may be the diagnosis of the patient. Okay, so the complication of SJS in a severe patient, they may present with acute complication such as massive loss of fluids, electrolyte imbalance, hypovolemic shock, multiple organ failure, bacteremia, and also abdominal compartment syndrome. Okay, since there are highly risk of getting infections, particularly bacterial infections, then they are also predisposed to any sepsis or septic shock, which is commonly caused by Staph aureus or Pseudomonas aeruginosa. And Pseudomonas aeruginosa infection is the main cause of death in this patient of SJS. Okay, and then they may also be presented with pulmonary complications, which include pneumonia, interstitial pneumonitis, and also increased respiratory rate, which may also progress to acute respiratory distress syndrome. Okay. For GI complications, it is resulted from the epithelial necrosis of the esophagus, and then down to the small bowel and the colon. Okay, so the patient may be presented with diarrhea, melena, small bowel ulcerations, colonic perforation, and also small bowel intussusception. Okay, so based on the pediatric protocols, the management, so the aim of the treatment is to remove the cause and also to prevent complication. So the management include the supportive care, specific treatment, and also monitoring of the patient. So for supportive care, we need to admit the patient to isolation room if possible. And then if we see that the patient is having shock, then we need to give IV fluid resuscitation. And then in treating them, we need to practice good nursing care like barrier nursing and also hand washing. And then if possible, we can use air fluidized bed, particularly if the patient had a lesion at their back area. So to avoid bad sores due to the pressure, then we need to use air fluidized bed. Okay, and then we need to also give adequate nutrition parenterally. Okay, and then for specific treatment, we need to eliminate the suspected offending drugs that we see it as the cause of the SGS, and then we give IVIG. So why we give IVIG? It's because it will help to arrest the progression of the disease and helps the complete re-epithelialization of lesions. So it will, like, in other words, it promotes wound healing for the patient. And then we need to also monitor the patient and always monitor their body temperature and fluid and also electrolytes based on their blood pressure and pulse rate. And then we also need to monitor their intake and output charts, as well as daily weighing and renal profile. Okay, so last one is the prognosis. So the overall mortality rate is 25%, ranging from 10% for SJS and more than 30% for TEN. And most common cause of death in this patient are sepsis, ARDS, and also multiple organ failure. And recurrence of SJS TEN may occur if the patient is re-exposed to the offending drug, like I said before. And then we can also use score 10, which is based upon 7 independent and easily measured clinical and lab variables. So we assess it rapidly on admission to the hospital. So this is the score 10, and the higher the score, the worse the prognosis, and it shows like the more severe the patient is. And that's this is my reference, and that's all from me. Thank you.
Good. Any question to Akila? No questions? Are you awake or sleepy?
Still awake, doctor.
Okay, so two important lessons I need to insist for you. Okay, number one, skin is an important introduction to our body. Many systemic disease can be diagnosed by skin. Okay, this is a very important, like SLE, dermatomyositis, like that. Okay, even rheumatic fever, you will find the skin manifestation, even Himandroma, a lot. If you started to go through the skin to go to the body, you will find cafe or spots like that. All this is introduction. The second one, even the lesion of the skin alone, we must be a good clinician and must be very professional, because most of that has clinical diagnosis. Only the investigation will help us, but it is not the one who is doing the diagnosis. That's why we must build up our clinical sense. I hope, inshallah, if any group come to me, they will try to, or I think you can add how to examine the skin, because most of you are able with time to do heart, chest, abdomen, nervous system, like that. But the issue with the skin, sometimes you are clumsy. What is the pathway? What is the flow to examine the skin? Who can do it? Just the flow. So I will ask Afika just to assign 1 or 2 person to do for us how to examine the skin. It is very important. If I found any skin lesion, how to comment on it. And you can send it to my WhatsApp, please. Okay, so don't forget these 2 important lessons. Try everyone every time, and then see some picture under the skin and ask yourself what is the systemic disease behind, and try in another era to see the skin lesion and tell us what is the clinical diagnosis. Or this one looks, because the rash is here, so it looks like scabies. Okay, This is hemangioma, even started in face like that. So this is superficial or deep hemangioma. Oh, it started the lesion now to be in the mucous membrane, in the eyes, in the mouth, in the nostril, in the genitalia like that. So I will suspect SGS. So it is very important to think how to come to the diagnosis. Okay. See you inshallah again, and just finish this one and give it to the group, waiting for that to give you your marking inshallah. Okay. Do you have any question before we finish this one? Okay, so just Bismillah ar-Rahman ar-Rahim wal asr. إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. وصلى الله وبارك على سيدنا محمد وعلى آله وصحبه وسلم. السلام عليكم. See you inshallah soon in the hospital.
Thank you, Doctor.
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 السلام عليكم.
Thank you, Doctor.
Welcome.
Thank you, Doctor.